तेरो नाम। हे राम हे राम, हे राम हे राम। तू ही माता, तू ही पिता है। तू ही माता, तू ही पिता है। तू ही तो है राधा का श्याम। हे राम हे राम, हे राम हे राम। सबका स्वामी, तू अंतर्यामी सबका स्वामी। तू अंतर्यामी सबका स्वामी। तू अंतर्यामी सबका स्वामी। तेरे चरणों में चारों धाम। हे राम हे राम, हे राम हे राम। तू ही बिगाड़े, तू ही संवारे। 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 इस जग के सारे काम। हे राम हे राम, हे राम हे राम। तू ही जगदाता विश्व विधाता। 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 तू ही सुबह, तू ही शाम। हे राम
Agreed, right? अच्छा डाबलस है।
हे राम हे राम, हे राम हे राम, हे राम हे राम, हे राम हे राम। जग में साचो तेरो नाम। हे राम हे राम, हे राम हे राम। तू ही माता, तू ही पिता है। सबका स्वामी
तू अंतर्यामी सबका स्वामी
तू अंतर्यामी सबका स्वामी
तू अंतर्यामी सबका स्वामी
तेरे चरणों में चारों धाम
तेरा
तू ही बिगाड़े तू ही संवारे
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 इस जग के सारे काम
तेरा 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 तेरा
तू ही
Welcome to this Shraddhanjali program of Dr. Shyam Joshi, sir. I'm sure none of us even imagined that we will meet virtually for such occasion. Today, sir may not be with us in this physical world, but virtually he will remain with us forever. Today, I do not know if there is any urologist exists in our country who is not influenced by sir either directly or indirectly. Our generation always wanted to be somewhere like him. The way he argued, the way he taught, the way he conducted teaching program, the way he operated, the way he had clarity of thoughts, so on and so forth. We acquired his characteristics and passed on to our students, and from our students to their students. So there is some Shyam Joshi exists in almost every one of us. People like Dr. Shyam Joshi never go away; they remain forever. There are many memories about sir in my mind, but we have so many other his contemporaries who will be talking about him. And but one thing I must say that I heard him telling so many times on various occasions, whatever we do, he always used to tell that the whatever you do, the academics always should be on the forefront. Whatever you do. So we thought that keeping some academic program, even at the condolence meeting, would be most appropriate Shraddhanjali for him. And hence we have organized a program of Shraddhanjali along with some academics. As all of us we know that pediatric urology was his passion. In fact, the motto of his life was to promote pediatric urology in India, and hence we have kept some academic program obviously related to pediatric urology. I must thank all the speakers, the national as well as international, for agreeing in fraction of second, which shows the kind of respect they had with Dr. Shyam Joshi sir. Dr. Asim Shukla, Dr. Pramod Mreddy, Dr. Douglas Canning have to be specially congratulated for the work and efforts they are putting to develop pediatric urology in India. I know so many times they come to India, do lots of teaching, lots of training, operate so many patients. So that's the kind of passion which they also have, which I'm sure Dr. Shyam Joshi also had about the pediatric urology. And hence I thought they are the apt speakers for this occasion. From India, Dr. Chandra Singh, Dr. M.A. Santari, Dr. Takwani are carrying forward the legacy of pediatric urology as he left, and they along with all others, I'm sure will make Dr. Shyam Joshi's dream come true to bring pediatric urology of India on the world map. The topics today we have chosen are so close to Dr. Shyam Joshi's heart, and I'm sure all the speakers will do justice in giving these academic talks. So with this, may I invite Dr. Asim Shukla first to give his talk on the primary VUR, how to manage in 2021. Primary VUR was the topic which Dr. Shyam Joshi loved to argue upon to talk upon, and so many other things. And I'm sure Dr. Asim Shukla will give justice to this talk. Over to you, Dr. Asim Shukla.
Thank you. Good evening to everyone in India. When I received the news of Dr. Joshi's passing, it was certainly a void came to all of our lives, and his voice, kept ringing. This photo from about 15 years ago with Pramod and myself, my wife Shubhaji, it really came to mind, and it captured the essence. This is about 15 years ago. I had met Dr. Joshi about 18, 19 years ago for the first time. His passion for pediatric urology was obvious. But the fact that he would take interest in a young person like me at that time, who was sort of developing as a pediatric urologist, and telling me, encouraging me at that first meeting that Dr. Desai and all of you organized in Goa, that Asim, if you commit to this, help us grow this in India, we will welcome you. And he truly welcomed me just as an Indian urologist, just as a friend, a young colleague, and a mentee who he mentored in so many ways with that proper Leeds Mumbai accent. I mean, he just impressed me with his scope of knowledge and the precise precision of his language and the precision of his skill. And he did love reflux. He did love talking about UTIs and reflux. We had many discussions there on the Big Island in Hawaii where Shubhaji was there. We had many discussions and many meetings. And speaking to Dr. Joshi, and this slide that Dr. Canning shared with me really brings it all together. This is the world of pediatric urology, or reflux, that Dr. Joshi was a part of developing and a witness to. From 1960 to 1972, the Politano surgery, the way he would describe, I saw him describe and demonstrate a Politano Ledbetter with the precision, with the passion, the way he brilliantly went through every step and how he taught that and inspired residents as just watching the beauty of that operation. He saw our evolution when Smelly came up with antibiotic prophylaxis. We talked about antenatal diagnosis and how congenital scarring can be seen. And then into the 1990s and now into the 2000s, he's been a part of this entire journey of reflux. And reflux, of course, consists of reflux, the anatomic problem, the bacteria, and the scarring. This was the pathophysiology that he understood. And he understood that, okay, if you have this children with a urinary tract infection, all of these children, say, have a UTI, about 30% to 40% of them will have reflux. And of that, only a small number will develop renal scarring. He knew that you can fix reflux. He did this operation beautifully. He could show that you could have excellent success rates, no morbidity. But he also knew, Dr. Joshi knew, that the cost, if we operated on every child with reflux, would be immense. $1.3 billion, so many BCUGs. He also knew that if you have abnormal bladder function, DES, it is associated with an increased incidence of UTI after surgery and an increased incidence of failure after surgery. He knew that it was associated with reflux resolution if you just fixed the abnormal bladder function and focus on that rather than surgery. And so we moved into the era of antibiotic prophylaxis. We moved into the era of who needs a VCUG, which child should have a VCUG. Now, we also know that at CHOP, this is some of the early work that was done when I was a fellow, and Dr. Canning wrote this paper, showing that our resolution rates are quite high, that even grade 4, up to 50% of these children, if you follow them long enough, could improve their reflux. But some would have a problem. And we knew that if you had a UTI and reflux together, you had more chance of scarring than if you had a UTI alone. And so in 1999, of course, we had the recommendation that of any child 2 months old and between 2 months and 2 years who has a febrile UTI should have a VCUG. But Dr. Joshi spoke about this passionately, that there are harms to doing MCUs and renal nuclear cystograms. They're invasive. They have reflux. They cause pain. And in fact, they themselves cause UTIs. And we also knew, and he was a transplant surgeon, Dr. Joshi, and he knew that, wait a minute, we're not seeing all of these children with reflux nephropathy or urine reflux going to transplant. Many of these are boys who actually did not have UTIs and happen to have reflux in association with dysplasia. And so in 2011, of course, the American Academy of Pediatrics changed this guideline. It said, first treat the UTI and no MCU after the first febrile UTI in the setting of a normal ultrasound, and only an MCU after the second UTI. And we learned to stratify white race, and actually Indian race matches very closely to white race in terms of incidence, and girls are at higher risk. Age less than 12 months. Boys, circumcision status is much more important than anything else in terms of urinary tract infections. And so we learned to look hard how to diagnose a UTI and to reduce a number of VCUGs. And look what happened. At 2007, when the NICE guidelines came out, and that dropped the VCUG MCU incidence significantly. And after the AAP, look how many MCUs just dropped off. And when the MCUs dropped off, look how reflux diagnosis dropped off. We went from, this level to that level. Post AAP guidelines, we saw an incidence drop from 45 around to about 25 per 100,000. So what did that do? We also learned from the RIVER trial that trimethoprim sulfamethoxazole versus placebo in children with reflux, antibiotic prophylaxis works. It reduces the risk of a urinary tract infection by 50%. But you had to risk stratify. You had to treat 8 children with febrile UTI to prevent one from getting a UTI. 8 children were exposed for 2 years or more of antibiotics to find that one who needed to treat. And so as we finish, let's look at the UTI EAU-ESPU guideline. And they changed from first febrile UTI, get an ultrasound. If there are no pathologic findings and you can treat the bowel and bladder dysfunction, you can focus on that. If you have reflux suspicion based on the severity of the UTI, get an MCU and then treat bowel and bladder dysfunction as necessary. But if you had complicated UTIs, upper tract dilation, then you're going to move towards more of a surgical pathway. And so we had general findings that UTI and reflux cause more scarring than UTI alone. A greater number of UTIs is associated with more scarring. Abnormal bladder function is very important. Continuous antibiotic prophylaxis works. And these are then the guidelines for management of reflux. And let's focus on the AUA, which is the one that we have been all part of developing here. And if you have a child less than a year old, even up all levels of reflux, we do continuous antibiotic prophylaxis. We circumcise the boys, and then we observe them. And as they get to be older than 1 year of age, if they have normal kidneys without bowel and bladder dysfunction, we will even consider stopping the antibiotic prophylaxis, even with reflux, and observing them. And only if they have abnormal kidneys and bowel and bladder dysfunction, and they get a breakthrough UTI, we move towards surgery. So how do I manage, and at CHOP, we manage reflux in 2021? Well, if you have reflux after a workup for antenatal hydro, it's a benign course, no UTI. We don't need to be even finding those reflux patients. And we know that they have a higher rate of spontaneous resolution than reflux diagnosed after a UTI. So we stop prophylaxis early and we circumcise the boys. If you have reflux without scarring, diagnosed post-UTI and lower grades of reflux, prophylaxis until toilet training, and surgery if you have a breakthrough UTI or persistent reflux after toilet training and high grades of reflux in girls. Reflux with scarring, we follow a different pathway, and grade 3 to grade 5, we'll consider surgery if the reflux is persistent after toilet training. But lower grades, we will stop the prophylaxis and really focus on bowel and bladder dysfunction. So I will leave it with reflux is still a clinical challenge. Dr. Joshi started this journey so long ago. And we continue to believe, as he often mentioned, that reflux is a wolf in sheep's clothing, or is it a sheep in wolf's clothing? We have to determine which it is and manage it accordingly. We cannot simply treat based on this grade, and there is no code to manage reflux. And what we learned from Dr. Joshi, those lessons stay with me as a child, as someone of Indian origin, born in the United States. the way he took me in, the tips and tricks that he brought me, and honestly, the way he opened doors for me to be here today with you. He brought me under his wings so that I could be counted among all of you and to offer whatever I can and to continue his journey and his passion in developing pediatric urology as a specialty in India. It was an honor to join all of you. Shubhaji, my deepest condolences, and to all of the colleagues who have trained under him. I consider myself one of his students and honored to have been on this journey with Dr. Joshi. Namaste.
Thank you, Dr. Asim. I think it was a wonderful talk, and I'm sure Dr. Shyam Joshi would have loved to listen to that talk, because whenever there was a reflux talk, he would spend time and again hours and hours of discussion on various aspects of reflux. So
Yes.
Thank you very much. Now, next I invite Dr. Chandra Singh, who is in Vellore, and he is the one, I know the struggle which he made in Vellore to establish the pediatric urology, having separate OPD, having separate operation theater, establishing as a separate branch, which now I think he has succeeded to do that. But the kind of passion which he also has with pediatric urology, I'm honored to call him for the next talk. Dr. Chandrasingh can start sharing the screen, and who is going to talk on the undescended testis, what urologists should know. Yeah, make full screen. Yeah, please go ahead. Dr. Chandra, you have to unmute yourself. On the top of the screen, first you can unmute yourself. Yeah, your slides are well seen. Just make full screen. You can unmute. If you are not able to see, then you can stop sharing, unmute yourself, and then start sharing. Because, yeah, unmute yourself.
Okay, yeah.
Yeah, now we can hear you. Now start sharing.
Yeah.
Good.
Sorry about that.
Perfect.
Yes. So I consider it a great privilege to share a few words about Dr. Shyam Joshi, because she has played a very, very important role in my life. I'd like to just share this email which Dr. Joshi had sent to Dr. Ganesh way back in 2004 after he attended the Pediatric Urology Conference in Belgium. And after that, he had mentioned that, his passion to select a candidate who will come back after fellowship and training. And we read, I have written to Mahesh Desai, Anand Kumar, and Rajesh Ailawat about this as well. You four HODs have the drive, vision, and workload to sustain. And in the middle, I've pasted what Dr. Ganesh had written. I have spoken to Shyam Joshi on this subject. And then after that, he said, when I had just joined as a urology trainee, he just wrote on this sheet of email printout and sent it to me for the attention of Dr. Chandra Singh. Dear Chandra, are you committed enough to take this on? This was when I was just starting my training in urology. And knowing that Dr. Ganesh meant the best for the department and institution and the urology at large, I said yes. And I'm glad I could keep that commitment that I made even before I joined as a urology trainee when I worked as a non-PG in urology under Dr. Ganesh. And those were the few words of introduction of the initial encounter with Dr. Shyam Joshi. Ever since that happened, as Asim mentioned, the next in-person encounter was in the Goa conference. And over there, I could learn so much from him on several aspects, especially the ones where there were a lot of controversies and difficulties. And one such area was undescended testis. And I will focus on a few things which we practice now which were also his points of view. So one of the things he emphasized on was a clinical examination. And one is in terms of the contralateral testis, which is larger than normal in size, say more than 2 ccc or greater, which could potentially be a predictor for a nubbin or atretic testis, which may preclude the chance of requiring a laparoscopy. Now, we know that this is not cast in stone, but the need for examination of the contralateral testis plays a very important role in our clinical decision making, especially in terms of when to operate and whether to go ahead with laparoscopy first. Then about epidemiology, this again is a very important aspect because the incidence drops drastically from a newborn preterm infant where the incidence is so high, and then it drops down to about only 1%. And as we all know, about 1/3 of those which are non-palpable have a non-viable testis, which may be just an atretic testis, an nubbin, or just blinding vessels. And 1/3 of them have extra-abdominal non-palpable testis, and about 1/3 have intra-abdominal testis. And of those which are intra-abdominal, 1/3 are known to be high and 2/3 are close to the deep ring. And this is where the diagnostic dilemma is when it comes to our management. And again, another favorite topic of discussion where I remember Dr. Joshi emphasizing is about the fallacy of doing an ultrasound. Because as we all know, if the pretest probability is not high enough to rule out, then it doesn't help us in our management algorithm. So one of the objective ways of using an ultrasound is probably to measure the size, especially following the oculopexy, and also to compare and measure the atrophy rates. But there are other indications that are often used when the clinically in those which are non-palpable. If nubbins may be picked up, we can avoid a laparoscopy. Or if a testis is very close to the deep ring, which is picked up in most ultrasounds, probably we may avoid a laparoscopy. In those who don't have laparoscopy is the first step in the algorithm. This is possibly one of the advantages that is quoted by a few which who do. But again, in terms of a community evaluation and counseling of a patient, of a child and anxious parents, ultrasound plays a very, very minimal role. Hormonal treatment, again, we have discussed at length in several of the conferences. And we know that in terms of promoting descent, the incremental benefit is very, very small. But possibly there is some role in better fertility rates in boys with bilateral undescended testis. So EAU recommends, though AUA guidelines do not recommend any hormonal treatment. Then the next topic of discussion is what's the initial approach? Do you, in those who have a non-palpable testis, do you do a laparoscopic approach first, or do you explore the groin, or as a few promote, you can still go ahead with the scrotal approach. If you go ahead with the laparoscopic approach, the advantage is that in those which are high, you can make an early diagnosis and you can plan for a stage Fowler-Stephens or a well-mobilized single-stage oculopexy. But the advantage of an inguinal approach is that in those which are nubbins or those which are close to the superficial and deep ring, we can avoid a laparoscopy, the time, cost, and the invasiveness. The advantage of the scrotal approach is that those which are nubbins, which are non-palpable, we can avoid even a groin incision. But there are a few testes which may be missed, which may be still intra-abdominal. So we need to decide, and each clinician can make a choice. But the most popular approach is to do a laparoscopy, then proceed oculopexy if the test is there. Next one is when to perform an oculopexy. And based on the various parameters, which are based on the probability of spontaneous descent, what is the impact on fertility, the sooner the better, what is the potential for malignancy, the ones which are remaining intra-abdominal till later have a higher propensity. And also there is a anesthetic concerns that there are adverse neurodevelopmental outcomes in earlier anesthesia. The optimal timing we know is somewhere around 6 to 12 months, and it's more towards the earlier time in the boys who have bilateral undescended testis. And intraoperatively, again, we need to examine under anesthesia because when a child is relaxed and not crying, a testis which is not palpable in the outpatient may become palpable. And also, Dr. Joshi emphasized on utilizing a lubricant and a gel to make the abdomen without any abdominal palpation friction free so that we can pick up those which are subtly palpable. especially in boys who are obese, we may be able to pick up when they are under anesthesia. This is one other area of hot discussion. The vessels that we see in the deep ring, there is some scientific evidence also. Those which are claimed to be vessels that are exiting the deep ring, there has been inconsistency in interpretation even among experienced pediatric urologists doing laparoscopy. Last couple of points to highlight on: one is paternity rates. And we know that the long-term follow-up rates show a markedly reduced paternity rates in men who have had bilateral Anderson testes compared to those who have had unilateral Anderson testes, where the fertility is about 89.5% compared to 94% in controls. And we also know that about 2/3 of those who have undescended testes, non-palpable and high testes have associated epidural abnormalities. And post-operatively, we know that the atrophy rates are not different if the octopexy is performed younger or in the older boys. Now, I would like to end with my last communication with Dr. Joshi. I had shared with him this particular email of what he had written to Dr. Ganesh and what after that prompted me to do. And I'm reminded of this quote: you can count the number of seeds in an apple, but you can never count the number of apples in an apple seed. And when I sent him this email communication, this was my last communication with Dr. Joshi a few months ago. And I wrote to him, "Dear sir, I was gratefully recollecting with my wife your role in my career, sending a copy of your mail to Dr. Ganesh in 2004. This was the response of this great human being. He said, "Thanks, the dream not yet fulfilled, but we have certainly made some good progress in the right direction." And now, though we miss him, we know the impact he has had on us and the inspiration that he has given and all what he has taught. And as he has rightly mentioned, we have made progress in the right direction, and we should all promise to take it to completion so that the children in India will get the best possible care so that they can survive and thrive and do well. And again, I would like to thank you, especially Dr. Sabnis, for giving me this opportunity.
Thank you, Chandra. It was a wonderful summary, and I think you have summarized it so well that I'm sure it will be very, very helpful to everyone. Next, I'm going to invite Dr. Pramod Reddy. You can stop sharing and let Dr. Pramod Reddy start sharing the screen. Pramod Reddy is one of the international speaker. He's from. He's also extremely passionate about developing pediatric urology, and especially for the development of pediatric urology in India. He has taken so much of efforts. He has offered training every time the people go to him. They are under fellowship. He takes so much of interest to teach them and understand the nitty-gritties of pediatric urology. And he's going to talk on a very, very a topic which is very dear to him, is dysfunctional voiding. Whenever the topic comes in, he used to talk so much about dysfunctional voiding and make sure that we should not forget this entity of dysfunctional voiding. So over to you, Dr. Pramod Reddy, for summarizing about the dysfunctional voiders in children.
Good evening, and thank you so much for allowing me to be part of this tribute to a dear friend of mine, Shubhaji, your family, and my dear colleagues in India. It's really a big loss to all of us, and my deepest condolences to all of you. As Asim has rightfully said, Dr. Joshi really welcomed Asim and I to be part of the journey of pediatric urology in India 15 years ago when we came to Goa. Actually, we came to Nadiad first, and then from there we went to Goa and had one of the first purely dedicated pediatric urology conferences. And Dr. Joshi was very instrumental in making that happen. And really, to quote Isaac Newton, if I've seen further than others, it's by standing upon the shoulders of giants. And there is no question that Dr. Joshi is indeed one of the giants in urology and pediatric urology around the world, not just in India. Dr. Joshi is certainly a beloved urologist, beloved teacher by any of his students. If you ask them, they all have fond recollections of their time with Dr. Joshi. He's been a leader in urology at the Urological Society of India and other international bodies, and certainly been a statesman for pushing the value and what Indian urology stands for and what it can offer to the rest of the world. and certainly been a strong proponent of pushing pediatric urology in India. I know a lot of you know Dr. Joshi from his time in conferences and his lectures and teaching, but I'd like to share another aspect of Dr. Joshi that I got to know, which is as a colleague and a travel buddy. So here he is in Hawaii with his first love, Shibaji, his wife, who is his best friend, confidant, and world traveling buddy. Dr. Joshi was always ready for an adventure. And, when we were in Hawaii, we went on many walks, and I remember taking across the large island car trip with Dr. Sheldon, Shibaji, and Dr. Joshi, and ended in a little chase by a police car, getting a ticket. But, it was such a great memory. And Dr. Joshi was also always ready to share a gathering with friends, make new friends, make new colleagues, and engage in discourse, whether it was just chit-chatting, whether it was talking about pediatric urology. There was one thing that you could always count on Dr. Joshi for, which was, one, to speak his mind without any hesitation. He was very forthright. And also his sense of humor. He had a wonderful sense of humor. He was very engaging and could make friends anywhere he went. And so I join all of you in saying that we will miss you. We'll miss your teachings and your sense of humor. But what you've left us with, we're definitely going to treasure and cherish. And those are our memories and the wisdom that you shared so freely with us. Dr. Joshi would always make fun of our focus on voiding dysfunction and say that voiding dysfunction was imposed on children by the societal expectations of Western society. And he would say, in India, where we let the kids roam around, without any concern for when they're going to be toilet trained, the incidence of voiding dysfunction was very low. Unfortunately, over the past 15, 20 years, as more and more parents have taken jobs and now the children are being exposed to the same sort of societal stresses, I do think that that is changing in India. And so Dr. Subnis had asked me to just speak about voiding dysfunction. And so let's talk about that. I don't have any disclosures to make. I think in order to understand voiding dysfunction, we have to understand what toilet training is. And all human beings, when we're born, we have no control over our bladder. And, we have infantile voiding, or what we call reflex voiding. And this is controlled by a sacral reflex arc in the S2, 3, 4 segments of the spinal cord. And this is the default voiding pattern for all humans. So if we take off the impact of the cerebral hemispheres, we will all be infantile voiders. And toilet training is the learned ability to inhibit or postpone infantile voiding, to take control of this and stop it from happening. It's important to understand that when this happens properly, that it does not involve the active contraction of the sphincter muscle, which is a striated skeletal muscle and under our control. So the children who have some element of voiding dysfunction, they learn incorrectly, whether it's due to being asked to toilet train when they're not physiologically ready, or due to some stress or trauma. They learn that this is, urination is painful, and so they learn to try and contract their sphincter to avoid it. Now, the AAP has guidelines as to what is appropriate timing of toilet training, and they identified specific developmental stages. So by 18 months, a child has the verbal ability to communicate bladder fullness, and they can, communicate to their parents or caregivers that they are having a sense of fullness. And by 24 months, they have enough fine motor skills that they can actually undress themselves, which is an important part, if you think about it, of being able to be toilet trained. They got to be able to undress themselves and go to the bathroom. And it's appropriate that most children, by the time they are 3.5 years old, will have daytime continence. And Dr. Curry, one of my colleagues and teachers from Toronto, would tell me that by the time a child can walk upstairs like an adult, alternating feet and pivoting up, they have enough neurological connections between their brain and the lowest part of their spinal cord that toilet training will be achievable. So that's a very easy thing to just check and watch a child walk. And if you see that they have good lower extremity control, they're probably ready to be toilet trained. Now that's daytime control. And if you think about it, a child will have daytime bladder control, nighttime bowel control, daytime bowel control, and then the last thing they could control of is nighttime bladder control. And usually we say that by about 4 to 4.5 years of age, most children will have achieved nighttime control also. It is important to note, though, that this can be delayed, and there are many factors that delay this, including family history. And we don't undertake an assessment of monosymptomatic nocturnal enuresis until a child's around 7 years of age. unless the child, not the parents, but the child comes to us and is highly motivated in trying to get dry at night. And this is just a normal uroflow that most of you are familiar with. There are three things here I'd like you to look at. One is look at the nature of the curve there. So the curve is a nice bell-shaped curve, and that's a normal uroflow curve. The volume of urine is what you want to look at, and the way we calculate the urine expected bladder capacity in a child is using the cough formula, which is their age in years plus 2, multiply that by 30, and that will give you an expected bladder capacity. So in addition to looking at the type of the curve that they have, are they holding and voiding a normal amount of urine? Are they emptying all the way? And also you want to look and see if the sphincter is becoming quiescent. As the bladder contraction starts, you should see that after a little bit of a lag phase, the sphincter calms down, and then there's a lag phase after which urination begins, and the sphincter should be quiet throughout the voiding phase. So if you see any sort of sphincteric EMG activity during voiding, that's also a clue that maybe that's part of the problem. Now, as Dr. Shukla talked about reflux and our improved understanding of bladder physiology and pathophysiology, I think this brings together another one of Dr. Joshi's passions, which is understanding what's going on with the urinary tract and how can we make this better without having to resort to surgical intervention. We do know that a lot of children with vesicoureal reflux have underlying bladder bowel dysfunction as the underlying etiology. And addressing this will, in a large instance, reduce the risk of urinary tract infections, but also allow for reflux to resolve once they're toilet trained. And so a lot of us now focus on any child with reflux. We will focus on bowel bladder dysfunction and addressing this very actively and proactively rather than rushing into surgical intervention. So this is a very common problem. And in the United States, it represents about 20-25% of the referrals to pediatric urologists, whether directly for incontinence or urinary tract infections or reflux or indirectly. And there's a wide spectrum of conditions, that range from daytime incontinence all the way through monosymptomatic nocturnal enuresis. You can have an underactive bladder to an overactive bladder, and dysfunctional voiding versus voiding postponement, where the child is avoiding going to the bathroom. And there's a very small subset of these children that will unfortunately progress to a very, very severest form of this, which is Hinman syndrome. I firmly believe that most children nowadays, with the lack of physical activity, lack of proper hydration, and eating more processed food, are more prone to constipation than ever before. And so you have to just assume that the children are constipated. If you ask parents, you take it as a slight to their parenting style and their ability to parent their child and feed their child properly. So they will say without question, oh no, my child's not constipated. But if you give them a chart and say, please document what your child is doing from a bowel habit standpoint, you'll see that about 85% of children are not stooling properly. And so we do ask the families to fill out a bladder and bowel chart for us, and we use a Bristol stool chart to help them assess the status of their child's bowel movements. So when evaluating bowel bladder dysfunction, the biggest tools are the simplest ones. And this is, again, another lesson that Dr. Joshi would always talk about is listen to the parents, listen to the children, and do a good physical examination. And that's going to give you most of what you need. And so the same thing, any child with bowel bladder dysfunction, the history and the voiding and bowel diaries are probably going to give you 90% of the time a diagnosis. A physical examination will fill in the rest of the 10%. And diagnostic imaging and other diagnostic studies are probably just complementary, but not always indicated. I would say that if you have a child who fails the initial treatment, then I would proceed with the more intensive diagnostic studies, but not as a first realm of going around in the treatment of them. So this one slide probably can summarize all the different types of bowel bladder dysfunction that we encounter. And the diagnostic dilemma is, can you identify which subset it is? And more importantly, not all children just have one isolated form of this bowel bladder dysfunction. As with many things in life, they're not as nice and tidy as they are in textbooks where we say, a patient falls into this category. Children may have more than one or two types of bowel bladder dysfunction. So starting with the most common one, which is detrusor overactivity. Here you have a child whose bladder just physiologically cannot hold a normal amount of urine. Their bladder starts to feel full at very, very low volumes, and the children have urgency, frequency, and oftentimes urge incontinence. And the first step here is to initiate a bladder retraining program, which will start with ensuring that they have appropriate hydration, avoiding any known bladder stimulants, going to the bathroom on a regular schedule, proper voiding posture, and learning to relax their sphincter. And when that fails, or if you see that they truly do have a smaller than expected bladder capacity, especially if they have daytime and nighttime incontinence, then maybe consider doing some anticholinergics to try and increase the functional bladder capacity. If it's truly just daytime incontinence and they can sleep through the night with a dry bladder, then you know that the bladder actually can hold appropriate amounts of urine. The second one there is then the detrusor sphincter discoordination. And here, the sphincter, instead of relaxing when the bladder is contracting, the sphincter is also actively contracting. And this we oftentimes see in children who have either learned to toilet train too soon before they were physiologically able to control their bladder and sphincter muscles, individuals who have had trauma. So it's important in the history to see if there's been any inappropriate touch or abuse of the child, children who've had recurrent urinary tract infections, or VCUGs, where we've had to catheterize these children. That's a painful memory for the children, and they associate those painful memories with the act of voiding. And so sometimes they will have voiding avoidance, and they'll try to tighten their sphincter to avoid going to the bathroom. And so here again, a bladder retraining is probably the utmost. And in those children who you see that on the EMG of their uroflow, that sphincter is just overly active, or they're failing to have resolution of their symptoms within 3 months of being on a good bladder retraining program, you can consider alpha blockers. Now, important to note that alpha blockers are not FDA approved for use in children, so it is an off-label indication. A third and a newly uncovered category, which is, we've known about this, but it was only in the past 10 years that we've actually given it a formal name, and that is detrusor underactivity, or a lazy bladder. And here the children just have learned to avoid going to the bathroom, and maybe they're severely constipated, and that puts pressure on the bladder neck, so they don't feel a need to go to the bathroom. And these children, their bladders just get overstretched, and so they can go almost all day without going to the bathroom. And they're at risk for infections. And so these children should be placed on a strict time voiding schedule, and also double voiding to ensure that they empty their bladder all the way. You can use alpha blockers to relax the sphincter. Their detrusor may not be able to generate an appropriate contraction, and so reducing the bladder outlet will make that weakened bladder able to empty better. And in extreme cases, one does have to resort to catheterizations. Nocturnal uresis should be treated in a category by itself, but understand that it may be associated with any one of the previous categories. And in nocturnal uresis, if you have a motivated child, and this is the key, it's not the parents that are motivated, but the child. That the fact that the parents bought that child to you tells you that the parents are really motivated. But if the child's not interested, has no desire, and is not bothered by the fact that they wet the bed, you're not going to be successful in treating that child and getting them to be dry. But in the motivated child, behavior modification, simple steps is making sure they empty their bladder before they go to sleep, reducing fluid intake in the evening. And then we really try and use the alarm system, because it is behavior modification. And you have to keep in mind that for a successful behavior to be ingrained in someone, it has to be done consistently for about 40 days. There are a lot of psychological studies that talk about developing and ingraining new behaviors. And so minimum of a month, but definitely by 40 days, if you can get a child to follow that and be dry, they're going to be dry. The beauty of the alarm system is there are no side effects. And in certain instances, we do use the oral form of DDAVP. There are fewer side effects than the inhaled version of DDAVP. So the take-home message is that evaluation is key to any sort of lower urinary tract dysfunction. It is important to identify what is the problem with the bladder behavior. Is it a failure to store urine, as in the overactive bladder, or is it a failure to empty the bladder properly, as in the detrusor sphincter discoordination and also the underactive bladder? The history, physical exam, and bladder diary are key, and targeted approach optimizes the treatment outcomes, especially if you can explain to the parents and the child what's going on. You're going to get more buy-in from them. And the majority of them, over 80% with appropriate guidance, will respond to behavior modification alone. You have to give it enough time. So it's really important to set parental expectations and the expectation of the child that this is not an immediate instant cure. It's going to take some time. They learn this behavior over a long period of time. It's going to take a long time to unlearn that behavior. You should address any of the comorbidities. We do know that physiological dehydration, constipation, developmental delays, and one subset is children with ADHD. They tend to be very, very recalcitrant to any sort of interventions. So I think setting expectations for those children is also very important. There are numerous pharmacological treatment options that we have, and those should be reserved for refractory patients. And biofeedback and pelvic floor physiotherapy has also been shown to be very helpful, but you need a motivated child and parents. Thank you very much for allowing me to share my memories of Dr. Joshi and a topic that he was very passionate about. Thank you for allowing me to be part of this beautiful tribute to Dr. Joshi. We will dearly miss him, and thank you very much.
Thank you, Dr. Pramod. Now, next I invite Dr. M.S. Ansari. M.S. Ansari is professor at SGPJ, one of the most premier institute of the country. He also has established himself as a pediatric urologist, and not only he himself has established himself, but he has started the fellowship in pediatric urology, and I know it is most sought after fellowship in the country. With this, I'm sure there are many students who take this pediatric urology and then subsequently come out as a pediatric urology, and that way he's contributing great thing towards developing the pediatric urology as a subspecialty in our country. So over to you, Dr. Ansari. He is going to talk on the reimplantation, Politono versus Cohen's. Politono Ledbetter was again, he's extremely passionate about this Politono Ledbetter. I know he was once, we had gone to Bangladesh and he was demonstrating the Politono Ledbetter reimplantation. Every step where there can be angulation, what step should be done, what is the pros and cons of each. Everything, he was so passionate talking about it. And I'm sure Dr. Ansari will narrate all those things, what he has learned from him. Over to you, Dr. Ansari.
Thank you very much, sir. Just a minute. Can you see my screen, sir?
We can see it very well. We can hear also well.
Okay. So, somehow this is not moving to the next slide. Let me come back again.
There are few departments at present in the country who are devoting themselves, or they have separated out pediatric urology, which are managed by the urologists. And SGPJ is one of the premier institute where the urologist has taken the burden of managing pediatric urology, and they are doing wonderful job. And you heard Dr. Chandra Singh also; he's also taken that responsibility. Yeah, Dr. Ansari, you can start now.
Yes. So I just, because all of us know that Joshi sir had not only a special interest in certain clinical entities in pediatric urology, but he also had some emotional inclination regarding certain technical surgical techniques also. As you rightly mentioned, it was not only the polytunnel Ledbetter, but I have learned a lot of things regarding the management of UBG obstruction. He was very passionate to teach the Anderson-Heinz pyeloplasty, the meticulousness, how to cut, how much to cut, and where to put your first stitch. So all of us, we learned a lot. He was really a great teacher, a great mentor for all of us. So this is a small homage and memoir, basically from my 2017 workshop, because we had almost 4 workshops. In almost all, we were graced by him. And this was the last case which he operated with me at Lucknow. And as we all know that he had a special interest for reflux. And this was a 3-year-old female who had breakthrough UTI, and he opted this case for polytunnel Ledbetter. Obviously, he also knew the secret that I am a strong proponent of Cohen reimplantation. So obviously, so when he scrubbed, there were a lot of questions from the auditorium as well as from the experts, and these questions were basically these: which technique, Cohen or polytunnel Ledbetter? What are their merits and demerits? How do you choose this technique? How do you decide when to tailor? and what is the criteria when to tailor these ureters, and does the type of surgical technique affect surgical outcome. But it was just a coincidence that he had a flight on the second day at 6 p.m. and the second case after this deflux injection was given allotted to him. So by the time he started the case, this was already 2 o'clock and he had a flight at 6 p.m. So this was a case of bilateral reflux. So he complete on the right side and he could reply some of the queries and the questions from the audience, which I will be addressing subsequently. Now, on the opposite side, there was less time, so he requested me to complete the procedure. So he met everybody, he thanked anesthetists, the surgical teams, the organizers, and went to the changing room to change. But after 10 minutes, he again reappeared in the OT. You know why? And he just peeped into it secretly what Dr. Ansari is doing, because he knew the secret that I am a strong proponent of Cohen. He thought that on the right side he has already done polytunnel lead better. I may finish away with Cohen on the opposite side. So luckily I had not thought to do the coin on the opposite side, and I was making a tunnel downward and creating a new hiatus to accomplish as he advised. So he was very happy and satisfied and left the OR. So these were some of the questions. So during the conversation between the audiences and Joshi sir, what he said agreed that no one technique may be suitable for all the cases, but still one need not to learn all, but practice few, master them, so as to give the best possible results. So that is very true in for reconstruction surgery. You need not to learn 100, but learn few and try to master that so that you give the best optimum results. So one of the questions which was asked, when you plan, how do you decide that this child will go for Cohen or polytunnel lead better? So these were some of the points which came out. These are some of the excerpts. As such, there was no mathematical formula by which you can say that this case is suitable for Cohen or this case is suitable for polytunnel lead better. Mostly this depends on the pathology as well as the choice of the surgeon. But what he said broadly, if you have already certain parameters which may guide you that this may go for which type of reimplantation. If you have a retrovesical diameter less than 15 millimeter or intraoperatively less than 10, then you need not to go to outside the bladder. Then you can easily get away with Cohen. This is justified. The case which is taken for Cohen reimplantation. And Joshi sir gave some of the examples that where you may require polytunnel lead better, where the retrovesical diameter is more than 10 or intraoperative diameter of the ureter is more than 10 millimeter, then you may think for the combined polytunnel, because these are the cases where you may need additional tailoring or tapering, or there may be other associated pathologies like ectopic ureter. Obviously, you need to go outside the bladder. Within the bladder, you will not find the UO to dissect it, and grossly tortuous ureter right on this side. And thirdly, if there is a large bladder diverticula where you need to dissect from the bladder outside, you have to go outside to take control that you do not damage the peritoneal also. And so he also said in his discussion that there may be other cases like ureter, which is loaded with multiple stones, or one or two where the child may need ureterolectomy as well as reimplantation, or there may be situations where there may be a complete duplex system along with the ureterocele. So what he said that these may be the cases more aptly suitable for polytunnel lead better, and obviously Cohen may be out of question for such scenarios. Then he said, why I opted polytunnel lead better. For the last 5 decades almost he was practicing polytunnel lead better, and he justified his viewpoint that ureteric hiatus is migrated superior to the original insertion. So that gives a long tunnel which can be created in cases of high grade of reflux as to maintain 1:4 or 1:5 ratio as suggested by authors. But at the same time, he also with great humility, he has accepted certain demerits. What has been said that there may be, since it may be a partially blind procedure also, because when you go for the migration of the hiatus, you go from within the bladder outside the bladder, and this part of the procedure becomes somehow semi-blind because you do not know what you are doing outside, like because there will be a wasp outside the bladder, you do not know, you might injure the wasp, and this has not been very historically studied separately. And secondly, what has been suggested is that there may be a kinking of the ureter, and you also told the nuances and the care which one can take to avoid the kinking of the ureter while you create the new hiatus. And this he also said that the polytunnel adbetter may sometimes may not be very suitable in case of a small bladder like posterior wall or neurogenic bladder. He further said, then what situations the coin may be more suitable, like for a small or thick wall bladder in PUV or neurogenic bladder. And it's also a good option when you are planning for an anti-incontinent procedure, bladder neck reconstruction, then coin is a very good procedure to accomplish. And tunnel across the trigone towards the contralateral bladder wall, it also gives sufficient to give anti-reflux mechanism. While the coin is also have this demerits in the because they also have some oblique course of the ureter. So subsequent endourological manipulation through these UOs become difficult. But now in the era of modern endourology, I think you can puncture either kidney also, you can go flexi from suprapubic road also. So that should not be a limitation to accept the coin as a procedure of reimplantation. As far as the last question was discussed, does the type of surgery affect the surgical outcome? And this one study from Belgium, which I could find, that this is the only study which is showing there may be slightly better results of Cohen in terms of correction of the reflux. But rest other studies, whether you take the IRS European arm, which consisted of nearly 237 refluxing unit, and this also did not show any difference or in success as well as the failures or redo surgeries. In subsequent studies also, this had almost 120. This did not also show superiority of one over the other. And this although it is a small study, this also did not show any difference in the surgical outcome whether you try polytunnel better or Cohen. So as far as the surgical outcome is concerned, the results are the same. The only thing you have to learn it meticulously and practice it so that you give the optimum results. And this is the last part of my talk. This is the last contribution we had with Joshi sir. Under his guidance, we prepared the Urological Society of India, and we are really thankful to USI and Professor NP Gupta Saab, who was the coordinator for making these guidelines for, and this is going to appear in 2021 in Indian Journal of Urology. And this was the great initiative by the USI, and Joshi sir has been a great instrumental for making these guidelines and guiding me and Dr. Chandra for making this manuscript. And lastly, I thank you, sir, that you will always live in our heart and what we are practicing. And there is a long dream which is still to be fulfilled. And whatever the legacy which you have left, and legacies always comes with lot of burden. And we will try to accomplish this task to take this torch further. And I thank you for this.
Thank you, Dr. Ansari. I'm sure you will carry forward the legacy which he has left. The whole development of pediatric urology burden is now on your shoulder. You people are the torch bearer of this, along with so many people who are inspired by Dr. Shyam Joshi sir. I'm sure will carry forward that legacy. So you can stop sharing, and now I'm going to invite Dr. Douglas Canning. He's going to talk on the proximal hypospadias. Hypospadias is, again, he was very passionate. Shyam Joshi sir was very passionate about it. And I know Douglas Canning, speaking about the multi-stage repair in the past, then promoting the single-stage repair, and now again going back to a single multi-stage repair. He also had a lot of encounters with Dr. Shyam Joshi, and he is the one who also is helping us in India to develop pediatric urology. So may I request Dr. Douglas Canning to start to give his talk. Over to you, Dr. Douglas Canning. You have to unmute.
Thank you. I just unmuted. Can you hear me okay?
Yes, we can hear you, and we can see your slides also.
Good. Well, first I must say that I am humbled, Ravindra, that you asked me to participate in this program. I was very sad to lose my friend. He was the first one who I remember crossed the room in my first USACON meeting in Delhi. I met him at breakfast. He walked straight across, introduced me. I was humbled that he even knew who I was, but it was the beginning of a friendship that I wish I'd had more time to develop. And I'll talk a bit more after I get through these slides. But thank you again. It's lovely to see so many of my Indian friends together at this time. My interest in hypospadias began with Bob Jeffster in my fellowship, but was refined when I got to work with John Duckett and Howard Snyder. And I like to start every talk with this image of John and his definition of hypospadiology, which is a difficult science that's humbling and energy consuming. In 1988, when I left my fellowship, this is what I had in my toolbox, basically, to fix hypospadias with. And I did a lot of Matus. I didn't get the opportunity, and I don't think I appreciated the importance of curvature and more proximal hypospadias. I would struggle through an island tube repair. It would take me 3 hours, maybe more, to get that done. But I did. The majority of the work that I did were staged repairs. We all know the procedures, the onlay repair here. These are just taken from Campbell's textbook. And the transverse preputial island flap repair, as John and Howard originally described it, was rolled over a tube. We no longer perform it that way at CHOP. We can talk a little bit about that in a minute. But by the time I got to about 3 years into my time at CHOP, I was trying to do single stage repairs with John and Howard watching over me with terrible results. And John came into my office and said, look, if you're going to continue to do hypospadias repairs here, you're going to have to watch me do them for a while because your results are terrible. And so it was a great opportunity for me. John did 3 repairs every Wednesday, and I would sit in there with him and watch him work, which was almost like a 6-month mini fellowship in hypospadias. And I asked him tons and tons of questions to the point of annoying him, I think, about what he was doing. But in the process, it helped me understand, and I think it even helped John understand why he did certain things. This is often the type of thing we would talk about. You know, at the end of the day, any reconstruction that we do depends on perfusion at the capillary level. Nothing will grow, nothing will take, nothing will stay the same unless there's good perfusion. And when you think about the end perfusion pressure at the capillary level, it's very close to 0, which means that you have to be very careful to make sure that whatever flap you're using has good perfusion at the arterial level, importantly. But it also is critical to make sure that after you put it all together, that you don't compress the flaps that you've brought into place by covering them overly zealously with dartos and skin that's at all tight. But this was the moniker. I mean, this was what we believed deeply at CHOP, and I think we still do, is that remote perfusion, the consistency of remote perfusion, regardless of the flap that you use, is critical to a good long-term result. And you can sort of look, I still believe that that dorsal perfusion is better than ventral perfusion by and large. That I think as you move down here, the blood supply, when you finally get to grafts, meatal base flaps, etc., gets a little bit less consistent here than it is over on this side of the screen. John and I talked a lot about that. By 2010, when I had mastered these types of procedures, I was doing virtually every operation as a single stage repair and getting good results, happy with my results. Still some patients that were getting stage repairs, particularly redo repairs. Here's a brief picture of how we do an island tube now. We turn it we suture down the plate, if you will, and then make an incision here and roll it and put a second suture line right next to the first suture line. And that, I think, allows us to trim these and make them less redundant and obviates any risk of twisting of the tube. And we get good results that are in many cases very durable. Here's a boy 5 years out from an island tube repair where I had taken the tube all the way up into the glands, which I will tell you for proximal hypospadias, I'm much more hesitant to do now than I was in those days because, our adult urologist, Caleb Covello, I just got off the phone with about a patient that I'd operated on almost 20 years ago now, who was having problems with the hypospadias, have taught us that our complications get worse as the longer we follow these patients. But we were very excited about it. And Asim Shukla wrote an important paper here that he called, that he asked the question, is the two-stage hypospadias repair, is it a misnomer? And his point was that in these 22 proximal hypospadias repairs that I did, many with Asim, we did 12 transverse perputial island flap repairs compared with 10 planned two-stage repairs. And 16% of these developed a fistula repair with shorter follow-up in this group as opposed to 70% requiring a third operation. So the point was that many single-stage repairs become two-stage repairs because we get fistulas with proximal hypospadias repairs and have to repair them. And likewise, many two-stage repairs become three-stage repairs when we follow them long enough because they often need to be revamped. It's interesting, though, I wanted you to hold this thought that we were counting successes here. And I'm going to make a plea that we should be counting our failures and looking more carefully at our failures. And we should be looking at the percentage of failures that we have as opposed to the percentage of successes, which I will show you is not always the same thing. And Rakesh Patel, who Asim identified, brought to America, became our resident in urology at Penn, wrote another paper together with Asim that looked at taking the onlay flap for salvage hypospadias repairs and reusing it to take half the flap to build a urethra with and half the flap to close with. And I don't have, this is not a talk about technique here, but I'm illustrating this because in those days we were writing a lot about getting this all done at one time. And some of the complications came back to haunt us. These are not all my complications, but some of them are. This one is, this one is, this one is. But when you write about complications, you get referred a lot of complications too. And most of my hypospadias career nowadays is fixing things that look like this when I get them, either at my own hand, but more commonly now from elsewhere. And I became interested in these complications because many of them were presenting much later than we were in the habit of following the patients. Haley Wood at the Cleveland Clinic published this back in 2008, making it clear to pediatric urologists that 31% of the complications she was seeing presented after 1 year. Shortly thereafter, Pete Hobecky's group showed that with long-term follow-up, that hypospadias complications were still being identified as long as 10 years out from surgery. And so we have to continue to watch these. This is from Leon Pierre Morcon's group, 47% after 1 year. So for me, the message was that we need to follow these patients right through adulthood in order to be sure that what we're doing works well. Here's a really, this is the paper though that turned my head. Luis Braga, Tony Corey was already mentioned by Primo, one of the greats here in North America of my generation. Armando, Darius Bagley, and Pippi Sally, who has come with us to India many times, wrote this paper that showed that in patients who had that came back with recurrent curvature, most of the patients that came back with recurrent curvature as a complication, which to me is my most feared complication, because if you have recurrent curvature, you need to completely take apart your repair in order to lengthen the ventrum of the penis, because those that were plicated came back at a rate of 28% with curvature versus those who had lengthening, ventral lengthening, who came back with redundant curvature, recurrent curvature 9% of the time. For me, if I have a patient who comes back with curvature, it means 4 operations over 6 years to get them fixed, because you no longer have tissue on the ventrum of the penis. And so, unfortunately for me, the seeds that I sowed in the first decade of the new millennial, between 2000 and 2008 or so, were coming back to see me 10 years later, in some cases with curvature, which was a big deal. This is not my complication, but this is a complication that Tony Corey shared with me from a very famous pediatric urologist that did a TIP repair on a patient, and essentially created a buried penis as this patient grew. This was 4 surgeries to correct this. Here's another boy who had plicating surgery along with a hypospadias repair, and the plications came down. And now he no longer has any skin on the ventrum of the penis, and clearly needs to have the urethral lengthened. In my hands, this is 4 operations. Barry Cogan, when he asked me to speak at the on long-term complications at CHOP, asked me to speak at an international meeting in 2014, scared me a little, because we began to look at our long-term 5 years or more out complication rate with hypospadias repair, and we were seeing about a 70% complication rate for proximal hypospadias. And the problem is that we were reporting 10 and 15% complication rate because we were mixing distal hypospadias together with proximal hypospadias, and that was resulting in a much better looking outcome pattern than was really true. If we looked just at proximal hypospadias repair, our complication rate was 70%. And I was panicked because I knew I was going to have to publish that if we looked at it. Fortunately, Edmund Gonzalez's group in Texas published a similar story. Aaron McNamara published the Boston series, 53% complication rate compared with 68% in Texas. Pippi Sally, 61, 52, and 38 for a long tip, a dorsal inlay, or staged repair, showed that the complication rates long-term were better with a 2-stage repair. And after 29 years at CHOP, for me, there hasn't been any place to run from these complications that have come back to haunt me. And I would say that just like Shyam Joshi, if you live long enough and you have a long history in one institution, it breeds humility and an appreciation that as time goes by, complication rate always increases. And so, unfortunately, it's never good news the longer you stay at one institution, because the patients will always come back to you, and they always develop new complications as opposed to getting better with time. But I will also say that it also drives a fierce desire to get better. This was Chris Long's work from that we commissioned, and we had a 43% complication rate for a 2-stage repair versus a 62% complication rate for for a single stage repair. Now, at first glance, Chris Long's paper could have been interpreted in the same way that Asim and I interpreted our data initially 10 years earlier. The mean number of procedures for a single stage repair was 1.94 for a planned single stage versus 2.48 for a planned two-stage repair. But that wasn't the whole story. The problem is that we count our successes and not our failures, meaning that we never really found out how many of these patients we left behind uncorrected. But if you count the unfixed failures and those that are lost to follow-up, here's an example of a surgical experience with single stage repairs. Many of these patients getting 1, 2, 3, 4, 5, 6, in some cases 7 reconstructions, still leaving a few patients behind. In this case, 8% of our patients were left behind unfixed. These were the number, 8% cripple rate is what I would call it if you do a single stage repair up front for proximal hypospadias. And here's the numbers for a planned two-stage repair. 1, 2, with 3 operations, all but 2% were straight and functioning. And to me, that's the difference that moved me back. I like to joke about it and say that, you know, if you buy a ticket to go from Philadelphia to Mumbai with a stop off in Doha, if you do a single stage repair, you'll get there 92% of the time. But 8% of the time, you'll be left in Doha with no opportunity to ever get to Mumbai. And so we don't sell plane tickets that way. We sell plane tickets that get everybody there eventually, even with a stop. And that's the message that I'd like to leave you with. And these were the types of things that I used to love to talk with Professor Joshi about, because he'd been there for so long and he'd seen so many problems that you know, I could learn a great deal from him. He was twice as far down his career than I was, and I listened very carefully because he'd done so many surgeries. So now at CHOP beginning in 2016, we began with closer follow-up, which involved hiring what we call a transitional urologist, and Caleb Cobell, who spends 1 day with us in peds and 4 days at the adult hospital, following up patients that are out 20, 30 years, teaching us about the things that work and about the things that don't work long term. And I would encourage everyone to find an adult reconstructive urologist that you can send your patients to when they grow up. So at CHOP, we're doing fewer single stage repairs for proximal hypospadias, and I do none. I no longer do any dorsal plication. I lengthen the ventrum of the penis if it has to be lengthened, and those become two-stage repairs for me. And we're really tracking those that we leave behind as well as those that we treat successfully. Complications present late. Staying in one center helps you learn. This is what we do now at CHOP. Very few distal hypospadias repairs as a single stage. We'll do island tubes if we can straighten them by cutting the urethral plate. But if they have more than 15 degrees of curvature, we lengthen it, and that becomes a stage repair. And so for proximal hypospadias, this is really just for proximal hypospadias we're talking about. These are all staged now at CHOP. So we've come full circle. And we did this in part because if we have to redo a patient who comes back with curvature, it's 4 stages, including the use of a scrotal flap usually. And now back to my friend. I told you how kind he was to me to make me feel so much at home in that hotel in Delhi that early morning when I didn't have Asim next to me or Primo next to me to show me around. Sam adopted me. And in talking with him, I learned that he looked at things in a similar way to the way that I like to think that I look at things, that his commitment was first to the child, not to the finances. His commitment was discovering a better way as a scholar. As a teacher, his time was not as important as his pupils. And so, you know, I was touched to hear that he ran a meeting once a week that would start at 9 p.m. and would run out as long as it needed to into the morning of the next morning. to make sure that every case was discussed. He was a happy man, and I think he lived a great life. He was humble, kind, generous. He was grateful for what he had, and he stuck to his principles to the benefit of the child and to his student. These qualities made him a happy man. His happiness made him attractive to all of us, particularly those of us that were coming to India for the first time. And this grace helped him connect on behalf of his children that he cared for, his students, and his country. So I'm sad that we've lost Shyam, but he left us all with a piece of him. Thank you.
Thank you, Douglas. That was a very nice narration that we have completed a full circle, and how Dr. Shyam Joshi also was instrumental in all the developments which have been taking place. Next, now I invite Dr. Anil Takwani. He's also carrying out the pediatric urology burden on his shoulder. He was closely associated with Dr. Shyam Joshi with so many panel discussions, so many interactions, and so many other activities of teaching and training in our country. So he's going to tell about the investigations which are advised in pediatric urology. And I know many instances, Takwan, you can start sharing the screen, that he was so particular, Dr. Shyam Joshi, about the investigation, and he would fire us if he advised the excessive investigations. And that is, I think, the clue which Dr. Takwani has taken up, and he is going to talk about the investigations in pediatric urology, the lessons learned from Dr. Shyam Joshi. Over to you, Dr. Takwani.
Is it okay?
Please go ahead.
Thank you, Dr. Shabnis. This is truly honor, and thank you to MPUH, Dr. MRD. And I am definitely privileged. Of late, I'm not only was his student, but may agree with me that I'm his boy. And that word still sounds even after 8-9 days of his passing. So when I think of Sir, impact he had in the field of pediatric urology, and at least on my academic career and on the careers of countless others, I'm almost at loss of words. But I'm never at loss of words. So what word actually describe you, sir? Mentor, role model, advisor, trusted friend and colleague, masterful clinician, brilliant educator, motivating speaker, Renaissance, and finally, visionary leader. Sir, you carved name on hearts, at least of my heart, and not on tombstones. A legacy is etched into the mind of others, and the stories they share about you forever. So we're missing these stalwarts in this pandemic time, and so I started talking with him, and he was also missing us. So somehow I and my wife entering his house. It was a clear lockdown in April, and with the help of Suba Madam, we could get the things done into his computer system, and we could arrange this webinar on 8th April. And he equally participated. It was a demand, huge demand from the trainees as well as from almost all corner of Euro Academy and ULTUA. And on finishing that that webinar, next day I got a message from the madam that thank you for arranging this webinar. My husband is in a good mood, happy, enjoying conversation with colleagues. This is a non-medical observation by a wife. Thank you. So this shows his excitement or his desire to remain connected with the students and the juniors or trainees, and his interest in the teaching and sharing the knowledge, and also reflects the concern or love of the madam and care of the madam to the sir. And this is the message, this email I received at the end of student teachers webinar, that he appreciated our efforts, and then he added that all presentations were very good, and I can understand that they have taken a lot of efforts, residents and mentors, and my personal congratulations to them, and hope this interest in pediatric urology will continue in future as well. So that shows his concern. As Venu has said myself, and Venu tried very hard to establish pediatric urology in USA. From that we can understand their efforts. But it appears this one program means, then again he appreciated the program. And he said that I pray and hope this will grow further. We may not have succeeded, but kept the interest going. Some feather in our cap, indeed. And then he adds that we had faculties from USA. Asim and Pramod are there. Listen, Asim Sukla and Dr. Pramod Reddy, I know them well and are frequent visitors to India and our conferences. Both are gifted surgeons and teachers. I have listened to their lectures and have enjoyed live operation, especially at Nadia. I am happy they have continued to help development of pediatric urology in India. And now look at this word. My pranam to these stalwarts from the USA. So that was his humbleness or his desire and to develop the pediatric urology and appreciation towards the people who contribute for the development of pediatric urology in India. So he said that thank you USI for this competition and hope you will promote pediatric urology for many months to come. But our unfortunate that he could not participate. He was to give us a blessing, opening blessing on 8th of November in global meeting, which he could not participate. And we missed him. On 7th, he called me from the ICU, but I was praying. I asked him first question that, sir, whether ma'am is there nearby you. He said, no, right now, no one is here. So I could ask you what going on. And then on 9th, I got again call that how was the webinar? See how much that man was curious, or how much he was having that intention to bring the pediatric urology further forward into the India. And when I told him that the Dr. Douglas Canning remembered him in his opening remark, he became very happy. And this is what these two gurus meaning for us that I think the Asim is the right person to recite this, because I am not that good. But Guru Brahma, Guru Vishnu, Guru Deva Maheshwara, Guru Shakshat, Param Brahma, Tasmai Sri Guru Mainama. So we know the creation Guru is Brahma, and duration of our life is Vishnu, and the things which passes through the trials, tribulations, and transformation, that is Guru Maheshwara. But this Guru who is nearby to us, he can only take us to the beyond. So, and make our, so I make my offering to the beautiful remover of my darkness, my ignorance, at least regarding the pediatric urology and urology, and I bow and lay down. So once again, very much thankful to MPUH, Dr. Shabnis, Dr. MRD sir, to give this opportunity. This is a big honor for me, not only for me, but all of us belongs to Euro Academy, ULTOE. And this is the last year. We exactly 1 year before we started Euro Academy, and that was dedicated to these two brilliant teachers, mentors. One of the Professor S.S. Joshi, and I request all of you to remain connected with Professor S.S. Joshi, being a regular member of Euro Academy. We have a lot of write-ups from the Professor S.S. Joshi, which will be archived and will remain there forever. And as I said that I'm lucky and it's my privilege also, as Dr. Sarnis mentioned, that since last couple of years in West Zone as well as in USI, I got very frequent opportunity to organize the pediatric urology program session. And this is, you can see 2016, we meet at Hyderabad, where Dr. Joshi is seen in the middle with this Christopher Woodhouse. And then again here it is IPL team which was organized at Indore by Dr. Kukreja. There you can see sir in the middle in the cap. And then at Lucknow, on insistence of Dr. Ansari, though Madam was refusing not to allow him to travel, Dr. Ansari invited him by heart and managed the travel and stay of both Dr. Joshi and Mrs. Joshi, and so that we can get that opportunity to interact with him. And I have seen the admirers, how much Dr. Ansari admires Dr. S.S. Joshi, and that he also expressed. And this is the last. He is on a dais again in the 2019 last year at Rajkot. Dawn is there at 80. It's not tired, not out, and we can still remember. We remember that clear sound or clear voice, an authentic voice at that particular age also. So we'll miss you, sir, without doubt, but you will be remain forever in our heart. And very quickly, I'm going through because I have taken some more time. So his insistence was not to do unnecessarily investigations, specifically invasive investigations like MCU and radiation involving investigations like again MCU, retrograde ureterogram, CT scan, IVPs for no reason. And he was always insisting that monitoring with careful sonography avoids unnecessary invasive and irradiating investigations. And for that, he was insisting always that he was giving an example that you was a pediatric urology, then how you converted yourself in a pediatric dedicated pediatric by your interest, by getting the patients, by focusing. So you start allocating, identify one sonologist, uh, go to his place, arrange several meetings, give a complete requisition form, start feeding him only patients, and see the outcome. And gradually, your dependence with the sonology, your reliability on the sonography reports and pictures will improve. And that is how you will be going away from the radiation involving or invasive investigations. Because for young generation, or most of the time when we talk with the Dr. Joshi, all argues that sonologists are not dependable. They are not relied because they give this. But this is what the trick he was suggesting every time when it comes to the sonology. And VCUG, I'm not going to go in detail, but his indications were very clear that visualization of ureter or dilated ureter on imaging, symptomatic with UTI. Here he said that suppose a patient of unilateral UPGO like hydronephrosis, but there is a one incidence of even clear-cut documented UTI. Definitely you have to go ahead with the VCUG because there are possibilities you are missing some significant reflux. Post-void residual for more than 30% in child, or abnormal bladder in bilateral hydronephrosis. There also he was having a certain preconditions that in case of bilateral hydronephrosis, however, if dependable sonologist reports that the ureters are not dilated in serial bladder level USGs, then VCU may be avoided. The message was that the VCUG, and even if in this kind of circumstances, if you are missing reflux, he was always telling that in my experience, I have not regretted my decision because those reflux are almost clinically insignificant. And then something about here you see how to treat these patients of neonatal hydronephrosis. He said that careful observation in stable clinical status, in stable morphological pictures, and in stable good renal function on diuretic scan. And these are the questions, again, like Dr. Ansari, these were the questions were coming to him very frequently. Is there any need of routine VCUG? His answer, no. And these are the reasons which we already discussed, that 2 to 3 USGs, if dilatations of ureter are not seen, bladder level with full bladder, don't do it, or even if there is a reflux, won't be clinically significant. Is there a need of repeat renal scan while you are observing these patients? The answer was no, till you are not changing line of treatment from observational to operative based on signal USG or symptoms. Don't do diuretic scan because that also involves a good amount of radiation. How to follow? He said that simply look at this patient clinically and 3 to 6 months sonography, which is very much available in India and it is still low cost. Which scan is better? Otherwise, he was insisting to EC. I'm in his contact since 2009. For long, many years, I was just posting the DTPA scan. He was asking repeatedly me. I said, that's probably it is not available radiopharmaceutical agent. He said, no, you just inquire. EC must be there. And if you are doing a diuretic scan for the UPGO-like condition, VUGO-like conditions, you have to use EC instead of a DTPA. And that is how I converted on the EC, and you all know advantage. I'm not going to go into detail, but the message is that you inquire with your radioisotopes scan center, and you will get the answer that EC is available, and EC is having the many benefits in the conditions of hydronephrosis. So when to do this scan, he said that 8 to 12 weeks as And then how early pyeloplasty? He was always insisting to let the child become 6 kg weight or cross the 3 or 4 months, and because that is safer for anesthesia. And will you do additional radiological examination like CT IVP, IVP or RGP? Is big no for the CT IVP. And at the most, suppose he says that you are not anatomically happy and you are still want some more details, he said that you can go for a limited plate or single or at the most 2 plate IVP, but most probably single plate IVP. And then at the time, at times, suppose if you need, you can do RGP, but provided you have a that pediatric instruments available in your armamentarium. And this is his argument always for the renal scan, that till 2 months, newborn is having a low GFR and GFR gradually increasing during the first 6 months of life. So these are immature kidneys, may be reflected in the renogram pattern by the plateauing and suggestive of obstruction for no reason. And immature kidney, second reason is that unable to respond diuretics like adult kidneys, and premature infants should be even older than 2 to 3 months. So this is very methodological, very clear messages for this thing. Again for the selection of radioisotope EC scan. And 2014 again, when I met first time at Lucknow, second time again in last year, but 2014 I think Dr. Ansari, remember it is the 21st year celebration of SGPGI, and he was probably given a talk on cortical transit time. These are the slides from the sir, and this topic was very close to his heart. We all know these slides are only available probably at the Chestlock Hospital because of his insistence, where there was a dedicated programming was there, and you can get a classical cortical transit time pictures as well as the proper calculation of the cortical transit time. And these are the two slides. One is of timely TTT, and this is a delayed transit time, cortical transit time. And then this was his very close to heart study, which was he always mentioned that in a patient with the split function still more than 40% or more than 40%, but this hydronephrosis worsening, then he said that cortical transit time is very much at our help, and severely impaired cortical transit time can suggest us that which patients is likely to require surgery, and even if we don't operate, then likely to deteriorate. So here you can see the 16 patients with the cortical transit time delayed, right? But a split function still 40 or more than 40, and they were operated. 10 showed improvement in the DRF, and 6 showed no improvement in the DRF. Now here is the cortical, when patients were observed, all 10 patients. In another group, 10 patients were observed, 4 showed deterioration in differential renal function. And this is another slide which was very close to his heart. That is from his in the institute where he got trained for the pediatric urology. That is Great Ormond Street Hospital, Sikkim. And this was very close to him. This was a study from Dillon regarding the correlation between the renal pelvic diameter and the most probably need of surgical intervention. And then this is the prognostic factors. You can he was quoting always that renal function less than 30 to 35%, epidiameter more than 30 to 50 millimeter, dilated calycis, and cortical transit time more than 3 minutes. So nowhere there is a mention of CT IVP. The reason is that if you see most of the time when the new generation post something about the UPGO like condition, they start posting with the CT or CT IVP, and you always saw his displeasure regarding this excess use of radiation, and he was insisting. And through this platform, I would like to request all the urologists, and specifically younger urologists, to give a thought before you prescribe a CT scan or CT IVP in a UPGO condition in a straightforward sonographical pictures. And these are his indications, and as initial diagnosis and then on follow-up. But he was always telling that the optimal interval for follow-up in order to avoid irreversible renal function loss and to achieve better compliance of the patients in the family remains unclear even after these many years. So he was always telling that we have understood, we have we have refined very much in the surgical skills, reached up to the robotic. But in last 40 years, or you can say 4 decades, our understanding about the prognostic factors almost remain there. And this is my last slide, that as I'm a follower of Kabir, that when the choice is given to you, when the Guru and Govind both are there, दोनों खड़े काके लागू पाए बलिहारी गुरुदेव की गोविंद युद्धि. So if you want to achieve that ultimate pleasure, ultimate freedom, and ultimate nirvana, that is only possible catching the hand of the teacher, or bow down to the teacher, because he can only take you to the ultimate nirvana of the life. Thank you once again for this honor, opportunity, and privilege. Thank you very much.
Well, thank you, Anil, for that excellent coverage of the topic. Well, that brings the end of this first session, and I know we are overshot too much from the time, but that again I think is keeping the legacy of Dr. Shyam Joshi. When it came to teaching and when it came to classes, I remember his classes. It was only the starting time was mentioned. No, there was only starting time. The ending time was never there. When he used to take classes for us, when I was resident in urology in JJ Hospital, the starting time was Wednesday night at 9 o'clock, but there was no end time. It was supposedly 9 to 10, but it used to end at 11, sometimes 12, sometimes 1 o'clock. So there was no end time. So I think when it came to academics, Shyam Joshi never bothered about time. He used to keep on going and going till such time everything was over. So I think that part we have taken the legacy of that. But at the same time, for the other things, he was very, very particular about timing. He insisted that things should start at time and end at proper time. So let us keep the second session on time. I request everybody to stick to time. And may I invite first Dr. Mahesh Desai to pay tribute to Dr. Shyam Joshi. Dr. Mahesh Desai. Please unmute yourself, sir. Yes, we can see. Just make full screen.
Me?
Yes, yes, we can hear you now.
जग में सुंदर है धूना चाहे कृष्ण कबू यारो जग में सुंदर है धूना चाहे कृष्ण कबू यारो राम श्याम
His name was Shriram Joshi. And that's his father, who was a very renowned ENT surgeon. And this is a Shyam. His name was Shriram, but he was known as a Shyam. So in his name, like Anup Jalota says, there are two names in the world, which is the best name is one is Ram and another is Shyam. And he, even though his name was Shriram, but people used to call him Shyam. So it was a wonderful. And look at the family, all five brothers, and all of them, I mean, four of them were doctors, and Madhav, who happened to be my wife's relation. His wife is married to her cousin, and he was an engineer. Lovely family. And here he is young. I'm going to share some of the photographs to celebrate his life. And here is he's with elder brother Sudhir for the thread ceremony. And here is Shobha Joshi. And today I came to know he was known that time as Jada Joshi. And that makes me happy, because when I was young, I was also known as Jada Desai, And this is Shyam. This is when he got his FRCS in 1971, and he was working in Great Ormond Street for a year with IMS William. After coming back, he joined, I think, Grant Medical College, and these were the stalwarts. For 3 decades, they promoted urology in India. and they made a USI, which is worth an organization internationally famous now. And Shyam was one of the active member, along with Dr. Fadke, Dr. Bapat, and Madhav Joshi, Madhav Kamath. And here, he also, when he was a president, he made USI international by having the international figures attending the conference here with the secretary Nagesha Rao. Both of them done wonderful job. This was his conference in 1988 at Vijayawada. And these three ladies, Shubha, Sudha, and Sukanti, they were always seen in the conference, and they were always supporting their husband whenever they are giving a lecture, a talk, something. I think they must be giving them the feedback of what they are doing. Here he is with the doyen of our urology, Dr. Bhatt and Raj Shekharan. And here, now in 1996, he started coming to MPUH in Riyadh and to help Dr. Bapat. Dr. Bapat was our postgraduate teacher, and that's why, because of him, we got a teaching assignment, and Shyam Joshi joined him. And then that was a really treat for the almost 98 students who has passed out from our hospital, and it is their effort. And then he was always there when there is an academic session. This is Paris Castro, who was in Nadia to demonstrate urotoscopy. And then he was a very keen observer. And every conference he used to listen. And then afterward, when we analyzed, he used to tell us what was right and what was wrong. But beside that, he had a love for the music. And here you can see that he is with the Gaikwad brothers, who's playing Jaltaran, and he was discussing the art of music with them. And then he attended all the musical program, and the both of them enjoyed the cultural program. He was not only a medical man; he had a non-medical group, and they used to have a great life together. And here you can see the president of the BAUS who has come to the Lucknow. He was with them. And here are many international people who have come. This is Dr. Bloom, and this is Dr. Hardy. And then he was active in the Urological Society of India. Here is the stalwart of the Urological Society of India, and he was always with them. And this is a three-old president, Roy Chelly, Nagesha Rao, and Shyam Joshi. Shyam Joshi is always there. Here he is seen with Dr. Razvi. Razvi is from Karachi, Pakistan, but this was in Bangladesh. But I know that he has attended many conferences in Karachi, which Dr. Razvi had organized, and they were great friends. And here with Ajay Kumar, Ajay Kumar will tell you the stories about him, and he may take hours to tell him. This is some of the stage we shared with Shyam Joshi. But he was a fun. He was a fun on the stage, whether it is an official function or if it's an academic function. And then in every conference, he would be there sharing the friendship and joy. NP Gupta will talk about it. And then, of course, he was a part of the MPUH, and he took part in every function which was done. Most important, he was a ladies' man as well. He was liked by all the ladies, especially his fun, and mostly there's some more pictures. And he is also instrumental in starting the pediatric department at the MPUH. And this is Amrita Patel, who donated the money, and he was instrumental in starting the pediatric thing. Here with Venugopal, Ajay Kumar, and this is a pediatric conference of USI, which we organized in Goa, which Ashim Shukla mentioned. And but when the time comes in the evening after the academics, he is there for dancing. and enjoying. I remember in one conference, the Shyam Joshi and the Shubha, they were labeled as the best couple for dancing. And then he was fun whenever there is a cultural program, and they were talking. Beside this thing is always serious during the daytime for the conferences, and the seriousness is transmitted to the students. And he was very keen. He used to sit till the last minute and watching and monitoring the conferences. But when we started the training program, then he was there for the laparoscopic animal study. This is on the pig. He was trying to teach the laparoscopy. He himself learned the laparoscopy, and here you can see that. So even age was no bar. I mean, for learning and teaching, he was good. And then after the hard work, he would mingle with the students, give them stories, sometimes jokes, sometimes music, and he was full of life. And many of our students, they know him. They know him so well. He used to know them all well. And this is one of those parties when we had in Naryad, where we used to have lots of hard work during the day, but fun during the evening. And for us, me and Nalini, Shyam and Shobha were the very closest friend we have for last 4-5 decades, and then we really enjoyed them. And here are their favorite student, Pipi Rao, Manohar, the Kochikar, and they all were trained. And you can see that this is our group in MPUH, and he was there. Remember, see that everybody is there, but he's always with the white coat. He respected the profession which he has, and he always was always seen with the proper white coat. This is, we shared many of our dreams together, our liking together, and how we can do. He tried to get the pediatric urology done when he was the specialist chairman of the specialist board in DNB. And after only so many years, last year I was the chairman of the specialist board, and we could get the 4 fellowship approved, and one of them is a pediatric fellowship. And here he's here with the BC Roy Award, a highest award in India, which is given to the best teacher, specialist, and the one who has done maximum work for the urology. Thank you very much. We really going to miss you, but your legend, your thoughts are always in our heart. You are not far away from both of us. Bye.
Thank you. Thank you, sir, for that complete journey of Dr. Shyam Joshi and his various other aspects. Now, may I invite Dr. Bapat, sir, to say a few words about him. Dr. Bapat, sir.
Hello.
Yes, sir, we can hear you.
Yeah. Good evening. And thank you very much for inviting me to speak a few words for my dear friend Shyam. Shyam, as I always called him, was not earlier part of my life a big friend. Indeed, we met in one of the conferences in Mumbai when I found him to be extremely critical and pointed out multiple faults in the speaker. At that time, I gathered the impression that here is someone who merely wants to impress with his knowledge and with his language. But this wasn't true at all. When we knew each other at Naryad, this was when I really knew Shyam as I know him today. An extremely pleasant, lovable gentleman extremely articulate, who knew his subject very well, and who would not tolerate any nonsense or any loose talk from any of the speakers. And especially when it came to a scientific topic and pediatric urology, he would jump on the speaker in case he said anything wrong. But this was one aspect of Shyam which we all know. But the other side of Shyam was what Mahesh pointed out a little while ago, that he was extremely social, very lovable, participated actively in many events, and as Mahesh showed, was active in many Nadiyat functions. And I recall very fondly one day when both of us sang a duet and were greatly appreciated. So this was one aspect of Shyam, a big very fond of music, as indeed was the entire Joshi family. It is very difficult to describe Shyam in just one word, but I can say one thing, that here is someone who you will never, never ever be without. I always look forward to meeting him at Nadiad and then subsequently in the scientific meetings in Bombay. And I came to admire him a great deal for his scientific knowledge, sharpness of mind, intelligence, and for his articulate language. We will all remember him all our life as someone who has left a deep mark on our mind and who we are going to miss him for a very, very long time. Sham, please remember that nobody is ever going to forget. You will always remember in our heart. In our heart, we will always remember you in our heart, and I want to express my deep sense of sorrow at his passing away. Only one little aspect I want to tell you, and that was his great fighting spirit. In spite of his illness, he was always humorous and would always take interest in what is going around. He would never ever give up and always look forward to recovering from his illness. With these few words, I would like to say that we are going to miss Shyam, and I want to convey my feelings of sadness and sorrow to Shubha, who also knew her very well, and she always was actively with him in Nadiad. Thank you very much.
Thank you, sir. Now, may I invite Dr. Professor Venugopal, sir, who is one of the active member and who equally is passionate about developing pediatric urology. And I know both of them had very, very strong bonding, not only from the friendship point of view, but for developing the pediatric urology as subspecialty point of view. So may I invite Dr. Professor Venugopal, sir, to say a few words.
Thank you so much. Can you hear me? Hello?
Yeah, we can hear you, sir.
Okay. I think it's very difficult for anybody to know about Shyam Joshi and his contributions to urology. I have been practicing urology for over 50 years now, and I know the pains and pangs that we had in trying to develop urology, even pediatric urology. My association with Shyam Joshi started in 1975 when he came back from UK and attended the first annual conference of the Association of Surgeons of India, the urology section at Chennai. Since that time, we have grown in friendship and camaraderie and very many things that we are all together. One thing that I remember vividly is the 1975 meet, which I just told you. And like what sir mentioned just earlier, that often with arguments, like typical of that he doesn't put any nonsense. The argument was about the terminology I used in my presentation as the title of my talk. And he was adamant, and so also I was adamant. And we had a long argument over that, which probably made us come closer together. And soon after, I understood and knew that here's a man who probably wanted pediatric urology developed in this country, and an area which I also had control interest at that time. And even today, my interest is pediatric urology. And though I dabble in most of urology, as a teacher who had to develop urology in this country, I had to deal with all aspects of urology. And that's what I did. Now, one thing that Shyam was very particular about was training of urologists. He brooded always about the tough war that was going on between the pediatricians, pediatric surgeons, and the urologists. I think it's a very, very unfair thing that is happening. And even today, I'm sure, though many things are mellowed down, but the undercurrents are still there as far as who should do pediatric urology. Is it the urologist or is it the pediatric surgeon? One thing for sure, to realize is that science does not belong to anyone. It belongs to everyone together so that we can have a model of teaching and training of the younger generation. And that's more the need of our work. Now, the most important other aspect is the two photographs that I have been showing. Can you show the picture again?
Yes, yes, sir.
Nice. The one is accessory. This is Shyam. I'll come to this later. Previous one. Other one. Okay. Now,
So these are the
we all talked about 1990 Pediatric Urology Conference at Goa and how well it went on. And Mahesh was kind of to show a picture of my receiving an award in that meeting also. But what is important for us to realize is the concept of pediatric urology in the country as a joint venture of pediatricians, pediatric surgeons, and urologists commenced or started or had its beginning in Manipur in the year. And this is a picture that was taken where I called Shyam as a father of Indian pediatric urology, and sitting with him is none other than the father of the doyen of Indian urology. So the two along with others are having a discussion, and this happened in 1990 at Manipur. I'm very proud of having the three-day program that went on without any interruption, and we discussed a lot of pediatric urology. Unfortunately, our dreams of developing urology further did not materialize. Again, long ago, I can't remember about 2016 or 2015 or so, we all met again in Nadia, and we had a 2-day session on pediatric urology, and in the evening, we tried again start the pediatric urology section, and that was the time when we started that we have to have, certificate courses for these specialties. Now, having said all these things, the most important thing that I realized is that without Shyam, there is no work. And Verno and Shyam were inseparable in the development of pediatric urology. I would like to end by saying I will hold to our memories until this life is done. It is in my heart. I'll sorely miss him where we can be asked for everything that you have done. And at the end, I must thank Shubha for all the help that she has given me time and again, not only to me, but for my wife also. That we were all very, very close. Thank you, Shubha, for giving us a
Thank you. Thank you very much, sir, for sharing those very, very old memories with all of us. Now, may I invite Dr. Madhav Kamath, sir, for to say a few words. Dr. Madhav Kamath was working with him in JJ Hospital, and he will share his memories about Dr. Madhav Kamath, sir, please.
हा कुठे दिलेला होता Shyam Pandit.
So meanwhile, if Dr. Madhav Kamath is not able to join, we'll request Dr. Percy Chibber to say a few words about him. Dr. Chibber, sir.
Yeah, sure. Can you see me?
Yes, we can see and hear you very well.
Can see and hear me very well. Okay, fine. A lot has been said about Shyam, so I'll just tell you my own impressions of this remarkable man. I first got to know him in 1982 when I joined the JJ Hospital as a young assistant honorary professor. The unit was at that time led by Dr. Kamath, and Dr. Shyam Joshi was avidly trying to establish pediatric urology as a separate specialty. He was more known for transplantations at that time because he was doing renal transplants along with Madhav Kamath at Jaslok, and Jaslok was spearheading the transplant movement in private hospitals across the country. I later on got to work with Shyam at Jaslok, maybe a few years, 7 years later when I joined Jaslok, so I knew him there as well. I won't belabor the point of his love for pediatric urology and what he's done and how he tried so hard to establish pediatric urology as a subspecialty in India. And to some extent, given the presence of Ansari and Chandra Singh and Takwani, I see some semblance of that dream coming true. So Shyam, I think that you'd be happy to see that this is happening, and maybe in the next 5 years, we will get a subspecialty of pediatric urology where people who do urology alone, pediatric urologists who do pediatric urology alone. Let me tell you a few things about my own impression of him. To see Shyam for the first time in the day put you in a good mood. He always had this quirky smile, something almost as if he had some sort of secret that he wasn't sharing with you. And he put you very much at ease. You just felt safe, nice, And as you know, that whatever was in his mind was quickly on his tongue, and with great conviction and reasonable amplitude of sound. So, and I'm to some extent a bit like that myself. So it wasn't infrequent that we would cross paths. Our discussions would be on other sides or opposite sides of whatever argument there was, whether it was urology, whether it was politics, or whatever. And the words would fly fast and fur would be all around the place. And we enjoyed that discourse. And at the end of it, we were it was almost as if nothing ever happened. So, and the other thing I always say is that he was an excellent teacher. He was a brilliant teacher, not because he was exceedingly knowledgeable, which he was, but because he had this kind of ability to link with his students. And I see this despite the fact that, again, with his students, he would fire salvos, merciless salvos. I mean, you couldn't say something out of order and not get a horrible sort of rocket. And but despite that, he would not intimidate the boys. They were never intimidated by what he said. Somehow or the other, they just knew that this is Shyam and this is the way he speaks. And so we are not going to be cowed down by what he says. And they would respond. And I can tell you one thing, I've been to numerous conferences and meetings with him. And every time I would be there and some student or some, student from the past would come and I would say, I know this guy, but I can't remember his name. And I would turn to Shyam and say, Shyam, who is that? And he would remember very well the boy's name, a couple of anecdotes of what he had done in the unit, and his wife's name, or if he could remember the kid's name. And that was not an an indication of his memory. It was an indication of how involved he was with his students. So completely involved. I mean, he considered them a kind of an extended family, and that is something. But the other thing, and last thing I would like to about, without over laboring the point, is his curiosity. Amazingly curious man. You could sit down and you could talk anything, and he would listen. If he hadn't heard of it before, he would press you with questions and try to learn whatever it was that you were teaching. Uh, that kind of curiosity demands a sense of humility. And that is one thing that came along with that, the curiosity and the humility. Marks of a scientist. These are marks of a scientist. In my book, these are the marks of a scientist. Dedication to the order. And lastly, I would just say that he was a fighter. I've seen him. I've seen him in and out of hospital for the last almost a year or more. And every time he was a little better, he was back there teaching the boys, taking classes and operating and, being what he was himself. And then again, we would hear that he's once again admitted. And so it was indeed, despite the fact that this was to some extent expected in this last ailment, we were still quite devastated to hear that he was no more. I'm sure he finds a secure place in all our hearts. And my condolences to Shubha, whom I've already condoled a number of times before. Shubha, you're a wonderful person, and you were a great companion to Shyam. And God bless you. God bless you all. May his soul rest in peace.
Thank you. Thank you very much. Now we have Dr. Madhav Kamath with us, and he is going to say a few words about him. Sir, please go ahead. Sir, please go ahead, Dr. Madhav Kamath. Please go ahead. We are able.
I can see Percy still talking.
Yeah, it is over. So now you can start speaking.
We have Dr. Madhav with us, and he is going to say a few words about it. Sir, please go ahead. Ravindra.
Yes.
Can you hear me?
Yes, we can hear you, sir.
Can you hear me?
Yes, please go ahead.
Can you hear me?
Yes, please go ahead.
Can you hear me?
Yes, sir, please go ahead.
Having a little problem. Can you hear me now? Shyam. Hello.
I think there is some issue with the sound. So may I request now Dr. Professor Roy Chalisar to go ahead and say a few words about him. Roy Chalisar. Please unmute yourself, sir. Please unmute.
Okay.
Yes, sir. Now we can hear you.
Audible?
Go ahead.
Okay. I must thank you for inviting me to this meeting, Sabnis. I've known Dr. Shyam Joshi and his wife Shubha for over 40 decades. They both used to attend all the urology meetings in the country. I used to attend these meetings with my wife. Over the years, we became good friends. Dr. Joshi was committed to the growth of urology in USA. When the Constitution of Arias Foundation was ratified in the annual general body meeting of USA in Bombay, he was very happy and optimistic. He threw a party to the office bearers of the Arias Foundation in the Bombay Gymkhana Club. I also had an occasion to visit his house. He was generous. They both were generous and warm in their reception. Dr. Joshi came to Calicut first time in early 1980s to attend the annual meeting of the Calicut Urology Club to give a talk. His talk one was on vesico-ureteric reflux, and this was very well appreciated. He came to Calicut again in 1990 to attend the annual Urology Society meeting, and again in early 2000 for a pediatric urology workshop. In the workshop, he had to operate on a child with a history of multiple failed surgery for a proximal penile hypospadias. He completed the surgery with the meatus at the corona. He declared that any attempt to take the meatus to the glands in this patient will not work. This was a pragmatic approach. And I think even today, for this condition, his approach is still valid. Dr. Joshi has traveled to all parts of the world and within the country to attend urology conferences. He has shared his experience in many conferences and workshops. He used to provoke heated discussions in conferences, and there were gems of knowledge to all in the audience. Dr. Joshi was very erudite in his pet subject of pediatric urology. He excelled in teaching and operating skills. He was invited to perform pediatric surgery in different parts of India. This shows his commitment to promote the specialty of pediatric urology in the country. Health issues for decades. He was never depressed or never bitter over these issues. He had a fighting spirit and always presented a cheerful outlook. His values and philosophy in life should be an inspiration to many. Honestly outspoken, sarcastic,
I think he has lost the connection, I think. So we'll go ahead with Dr. Ajay Kumar, sir. I know Dr. Ajay Kumar and Dr. Shyam Joshi had very, very close bonding. They have traveled together, they have stayed together, they have done so many things together. And may I request Dr. Ajay Kumar, sir, to share a few things about it.
Thank you, Sabnis, for giving me this opportunity after long tributes by my seniors. I will not take long, don't worry about it. Just let me tell you, 1975 September, I had landed from England after 10 years, about a decade in there, straight in Delhi conference. Of course, I was very young, lean and thin. People thought I was a postgraduate somewhere. The seniors thought. And I became little visual in the conference because of my outspoken attitude. And I was criticizing everything what was going on in different halls. In the evening, may his soul rest in peace, my great friend, Jasilan Matyas, my good old friend. He just comes in. I am a guest house, which was natural because he was in IMA, but with him, a very dynamic face, the young man came smiling and just said, "Oh, I just wanted to meet you." I asked Jayashilan, "Who is this young man?" So he told me all about you. So I have come to see you here. Great, nice meeting. And that shake hand continued for another 37 years. I would not waste anybody's time by saying who he was. He was, Percy has said everything, he outspoken at the top of his voice, Ganesh, I can see he will remember our general body meetings, my, togetherness with Shyam Joshi, making general body little exciting and all. But two things of Shyam, I'll tell you. Now, we used to travel abroad. We used to stay together. Shubha is listening. She is seeing me. My wife Sudha is also sitting here. So many times Shubha, him, me and my wife, sometimes Mahesh Bhai and Bhabhi, and we used to travel together quite a lot. In different places, we used to have fun. It's a long story. I'll keep on, narrating for hours today together. But one thing I remember still, once I had invited him to Patna, him and Shubha, just for a sort of holiday type of thing. There was his own conference here. I was at the helm of the affairs. I said, we just come for this June conference, deliver a lecture, and then we'll go to Bodh Gaya, Rajgir, and all together, myself, my wife, you and Shubha. And they made a program. In the meantime, I had very severe infective hepatitis. I was down with it, and actually it was so serious that I was in bed for almost 1 hour before, 1 year, a month before he was, supposed to be arriving. I didn't want to spoil his fun. He had, prepared all the program and all. So I told my people that what you do is you take him straight from airport to the hotel. Usually he used to stay with me several times. Him and Subha have stayed, and with other friends, we had pediatric urology workshop here. Venu also stayed with him in my house. So anyway, then they started taking him to one of the hotels from airport. He said, you are taking a right turn. No, 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 no. Ajay's house is on the left-hand side. And then they just wanted to, ignore what he was saying, took him to hotel. He said, you brought me to hotel. I was supposed to be staying with him. Then they had to tell what was the problem. And I didn't want to spoil his fun. I had arranged everything for him. He said, look, I have come here to stay with Ajay. And especially when he is sick, I must stay with him. Don't unload my way. That was his way of saying, don't unload my luggage and take me straight to his house. He came to my house along with Shubha. Shubha will remember, 5 days. 5 days. 5 days they stayed with us. And I don't know what happened. During that period, we used to have fun. We had Havan and on. I got better also. By the time he left, I was already feeling better. So that is one thing he had. He had concern for his friends. He was very tough from outside. He was like a coconut, I tell you. Outside, very tough shell. Inside, he was really soft and nice person. One more story I'll tell you because others have taken time. There was one young urologist who wanted to get himself as a consultant in Jaslo. And somehow or other, Shyam did not, sort of like him to come. I will not elaborate any further. And I was trying to do some, parry with him, let him. No, there was certain reason. No way I am allowing him to come to this. Then ultimately, after certain discussion, I got him agreed to say that, okay, it is like Mahabharata, Ashwatthama Hato, Narova Kunjuro. You keep quiet. You don't say yes or no, things will happen. So things happened. He became consultant. And when I held the Pediatric Urology conference in Patna, a workshop, Professor Bapat had come and sort of Venugopal, him, and they were all staying with me. When he saw the same chap in the flight with him, he said, where are you going? He said, I'm going to Patna for the same workshop. He came and straight told me how he is coming to stay in a workshop. It's okay, Why I'm saying this? That he had very strong feeling, likes and dislikes. But later on he became sort of all right. So there are many things I will keep on saying. Others are waiting, getting late. The only thing I will say, I will miss my friend, my philosopher, my guide. And still I don't believe that Shyam is not with us. His physical presence may not be there. His spirit will remain till me and my wife and my friends, myself, Mahesh Bhai and Shyam Joshi, for a long time we had him. So yeah, he will remain with us, and I will pray that he keeps on blessing us so that we have a life, where we don't feel the void he has left to us. And Shubha, me and Sudha are sitting here. We love you, Shubha. And I hope very soon you are coming to Patna to stay with us. Thank you very much, sir.
Thank you, sir. Now may I request Dr. Nageshwar Rao sir to say a few words.
Oh my, Mata Washroom.
Sir, unmute yourself, sir. Nageshwar Rao sir.
You hear me now?
Yes, we can hear you well.
Okay. Shubha and dear friends, really never thought it will occasion like this will come, that we hear about his no more in this world, but he is in all our hearts. I know he's a very lovable person. He's very, very humble, and absolutely we remember myself and Roy Chelli on our way to Nadiad. We stopped at Bombay. We came to your house. You remember, Shubha? That time, your mother-in-law was there because we were staying a few hours and taking the train to Nadiad. And she said she's a traditional family business like that. She said she offered us all in the night before we leave some product made of, I think, milk, curd or something. Said it is auspicious. So I don't know whether Shyam is that religious, but he used to say, when I said, I had the privilege of working as a secretary for 4 years with Ajit Patke, Shyam Joshi, Roy Chelli, Raj Sekhar, all the giants of the urology. That's at that time I said, today I can't have banquet, I cannot come, Shyam, because today is Ekadasi. Oh man, you practice more Brahmanism than I do. How come? So he's very, very frank, outright, he will speak. And Ajay arranged our trip to Kaziganga. Remember Ajay? So we had a very fine time there.
I remember very well that trip.
Yeah. We had enjoyed that very well at that time. Sudha, and as Mahesh has shown the photos. And luckily, both of you were in my house. We spent a couple of days teaching all the residents, all the trainees in the urology at that time when I was running the DNB program. And also he did a pediatric surgical procedures in our hospital. Of course, Roy was there. Ajay also was there at house. He came. So Ajit was there. So many people have visited. We are fortunate to have that. And I also used to tell once there is a meeting in Benares. He was coming, he was joking, he's very humorous. And he used to say, how come you are so late? I said, no. Shubha, you remember? He said, you came by car because there was so much of fog. He said, Nageshwar, what to do? We are walking behind the car because the fog is so much. So that is how he used to express. And unbelievably, that I have the nostalgic feelings about him. We learned a lot. He's a good friend of ours. And I'm sure, with the help of the grace of the Almighty, he will attain Sadgati. And don't think he's not there. He is with us all the time. and we miss him personally, but by heart he is with us, and wish you all the best. May God bless him. Thank you.
Thank you, sir. Now, may I request Dr. N.P. Gupta, sir, to say a few words.
Thank you, Sabnish, for asking me to join to pay our tribute to our dear friend Dr. Shyam Joshi. I met him for the first time in middle of 80s when I went to. Are you hearing me?
Yes, we can hear you, sir.
Okay.
Very
When I went to JJ Hospital to as a examiner for MCH student, and that was my first meeting with him in Bombay, and I remember the hospitality which he has provided to us. And after that, we used to commonly meet in all our meetings later on. All our friends have already mentioned about his qualities, as he is a good surgeon, good teacher. He has a very good human being and very enjoyable person. So I will not repeat all that, but I would like to share. Go back, please, the previous one. Previous one. I'd like to share you with this one picture which I have for the 8th Asian Congress of Urology. And this session was by Dr. Anthony Atala, whom you all know, and who is going to deliver the AUA lecture on regenerative urology. And we decided that we should have Dr. Shyam Joshi to chair this prestigious session in this congress, which was the most prestigious session. Why? We know because of his interest in the development, progress, and in the science and development of the new things which is happening, because that is also like his passion for the pediatric urology, which you have heard. And then this is Dr. Murai from Japan. And in the evenings, next week, as you all have heard, he will enjoy, he will share, and he will enjoy the parties. He will have jokes like that, and he is a very lively person. And then the last photograph which I like to show you, this is the all past presidents of the Urology Society of India, which was taken in UCCon 2018 in Jaipur, and Shyam is here. And he used to be very active throughout the our UCCon meetings. All the 4 days his presence is there. He used to take very active part, and as you have heard, his criticism was always constructive, and he was very meticulous, listening to the lectures and attending everything. So Shyam, we will miss you, and but we will always remember you. I'm sure your love, the pediatric urology is now establishing in our country. We have already, national board has recognized fellowships, and I'm sure in future this specialty will grow, and we will always remember you as father of the pediatric urology in India, as Dr. Vinu Gopal has said. Shobhaji, our condolences to you and family. And we have met you also in our meetings. My wife, Usha, always remembers you, and she also conveys her condolences to you and family, and courage to you to bear his loss. Thank you very much.
Thank you, sir. Now, may I request Dr. Ganesh Gopalakrishnan, sir, to say a few words.
Thank you very much, Sabnis. Can you hear me?
Yes, very clear.
Ganeshaya Namaha was the phrase that Shyam would address me at every meeting. That's how he would greet me. And then after that, he would proceed to expound his Tamil with me at every meeting, definitely a paragraph or two of Tamil that he would share with me. And then we would proceed to the bar and have our drinks, and then the merriment would start. Today, all my friends today have tried their very best to find the right adjectives to describe Shyam Joshi. But sadly, there are no words left to actually describe him. There is actually no word to describe him in the language that we know. And therefore, all I can say is Shyam is humanness personified. There is nothing else that we can describe Shyam Joshi as about. And in his loss today, I can only remember the words of the great poet Rabindranath Tagore. Death is not extinguishing the light. It is only putting out the lamp because the dawn has come. God bless you, Shubha. And thank you very much to everybody and to you especially for helping us to know Shyam as he is. God bless you.
Thank you, sir. Now we have Dr. V. Sripathy, who has joined us. He is the past president of Society of Pediatric Urology, and he wished to say a few words about Dr. Shyam Joshi. So, Dr. Sripathy, please go ahead. Dr. Sripathy, you have to unmute yourself. I think there is some problem with the connection. Now, with this, we come to the end of this tribute session. Now, before we end, the Dr. Asim Shukla wants to recite with his wife something. So, may I request Dr. Asim Shukla to go ahead and recite? Dr. Asim Shukla wanted to say a few things, and he wanted to recite Guru Brahma. Well, if he's not there, I think we come to the end of this tribute session. I must sincerely thank all of you for.
Ravindra, if it is only saying Guru Brahma, I will say it.
Yes, please go ahead.
Great teacher.
Yeah, so please, please go ahead, sir.
Teachers don't teach for income. Teachers teach for outcome. I think all of you agree. That's what we have to learn. And Guru Brahma, Guru Vishnu, Guru Devo Maheshwar, Guru Sakshat Parabrahma Tasmai Sri Gurave Namah. Akhanda Mandalakaram Vyaptam Shariram Jnana Sesham Jnana Timirandasya Jnana Salakaya Sikshun Miratamena Tasmai Sri Gurave Namah. Aneka Janma Samprapta Parvanda Vibhajne
Thank you. Dr. Asim Shukla, you want to recite?
No, I spoke to Dr. Takani. I was just...
Okay. So I must...
That's also recited.
Asim, you have to meaning it. Asim, you have to meaning it for all of us.
No,
you are the best person to meaning. Yeah, no, please go ahead.
It was said. I have nothing to add. Just just a respect to our guru. The guru is like God for all of us, and with that same spirit, I think all of us have gathered here, admirers of Dr. Joshi, and recognizing this legacy, and seeing all the stalwarts here, who are his friends, his contemporaries, his peers, and his students. I mean, I was just telling my wife that someday, when the time comes, this is the type of Shraddhanjali that I think, as pediatric urologists, we would always want. What a great memory and great time. I hope Subhaji enjoyed as much as all of us have. So thank you.
Well, with this we come to end. Shubha Madam, this is the, you all know that there were so many other people who wanted to say a few things, but we had to cut short, and we had the restriction of time and number. But there are many people who wanted to express what they felt about Dr. Shyam Joshi sir. Many people have enjoyed and had a lot of memories about him, but we had the restrictions, and therefore we end the session at this point of time. And I must thank all the faculties, all the senior contemporaries of Dr. Shyam Joshi sir for joining us for this condolence meeting. I also thank our overseas friends who have joined at odd time in their own countries, for sharing their memories with us. Yes, sir.
Shubha would like to speak something.
She would. Dr. Shubha, madam, please go ahead. You can unmute yourself.
To all of you, and thank you very much for such a lovely program. And Dr. Shukla, I still remember our trips and what fun we had over there with Dr. Reddy also. all of you. And I'm going to miss the conferences. We both used to attend and we used to love it. Shyam loved the conferences. He loved to meet his friends, his boys as his students. And I used to also enjoy with Nalu, with Sudha, with all of them. It was fun. It was a family. It is urology, all urology is the family. Thank you very much for
Thank you, madam. Dr. Shyam Joshi sir will always remain in our heart, in our mind, and in our work. And whatever legacy he has left, certainly we will carry that forward with the efforts and with the teaching what he has given to us. So once again, thank you very much, and I thank all of you for joining us for this condolence.
Ravindra, we thank Mahesh.
Shubha, you will be always welcome to every conference.
Yeah.
Nalini and
Wherever you are, if you are there, I'll come.
There, we will be together always.
Yeah, thank you.
Okay, bye.
Thank you. Bye. Bye.
Thank you, Dr. Sabnis. Thank you. Bye.
Shubha.
Bye, Adil.
Bye.
Everyone for a beautiful tribute.
Bye, Dr. Reddy.
Sir.
Bye,